morning. Excuse me. Good morning. My name is Dr. Stephen Little. Welcome to the Education Studios at Methodist DeBakey Heart and Vascular Center. It's my pleasure today to welcome Dr. Rebecca Hahn, coming to us live from New York City, Columbia Medical Center. In a moment, Dr. Hahn is going to really entertain us with an interesting talk about the heart team in 2021 and the role of the interventional imager. For those who aren't in echo and for those who don't do interventions, I will briefly try to introduce Dr. Hahn. For those in those fields, she certainly needs no introduction. Dr. Hahn is professor of medicine at Columbia University Medical Center, New York. She's the chief scientific officer for the core lab at CRF. She was appointed director of interventional echo at Columbia Valve Center in 2011. She's an active member of the American Society of Echo and has really played numerous roles. I know many of them and have the pleasure to work with Dr. Hahn on many occasions. She's been a past board of director. She has been on the scientific planning committee, and she really has been pivotal in the writing of many guidelines, and I'll touch on those in just a second. She has published over 250 articles, principally on echocardiography and now in clinical trial work. And she's written really the guidelines, or she's contributed substantially to the guidelines for performing a comprehensive TEE, recommendations for the non-invasive evaluation of native valvular regurgitation, guidelines for the evaluation of valvular regurgitation after percutaneous repair or replacement, and the guidelines for the use of transesophageal echo to assist with surgical decision-making. She's also been very involved with the Academic Research Consortium writing committees and has contributed to the VARC-3 documents and the Paravalvular Leak Academic Research Consortium. And most recently, she's been the national PI for the SCOUT trial and the national co-PI for the TRISCEND pivotal trial. And currently, today, she participates in over 100 clinical trials at Columbia University. So we're really very lucky to have Dr. Hahn present to us this morning. Just before we go to Becky, I just want to tell the audience the important part of this morning is the interaction at the end. So I just want to give you the tip on how to send in some questions that hopefully we'll have some time at the end to get to. To do that, I think it's scrolled across the monitor, but it's really go to pollev.com, enter DeBakey, and then reply to the activity, or alternatively, you can text in a question. You text DeBakey to 37607, send in your message, it'll appear here, and I'll try to coordinate and get all those questions to Dr. Hahn. So without further ado, Becky, welcome to Houston Methodist virtually. We wish, of course, you were here in person, but we're very happy that you're able to talk with us today.
Well, thanks, Steve. Thanks a lot for the really generous introduction. And I really also am pretty sad that I'm not there personally, but I think that it's coming soon that we'll be able to have these in-person meetings. And I really want to thank you and you know, all of cardiology for inviting me today to speak about something that I obviously feel very strongly about, which are the new roles of the interventional imager. These are my disclosures. And hopefully today you'll understand the essential role of multi-modality imaging as well as the imager, and then review some of the advances and appreciate how structural heart disease really has been transformed by imaging, and then recognize some of the training challenges. Early in 1999, during one of the TCT meetings, Dr. Leon had coined the term structural heart disease. And this was really an overarching term to incorporate all non-coronary interventions. And then shortly after that, he coined the term interventional echocardiographer in reference to a position that he had made for me within CIVIT, which is our interventional group. And what we had learned during the partner trials, and we're going to start with some of the partner trials, but what we had learned throughout these trials was that the heart team was really made up of all of these components and participants, but that the cardiac imager ended up playing a really central role. And most recently, this was just published out of the Netherlands. We now have some evidence that the heart team actually is an integral part of how we manage patients. And you can see here from 1,100 patients, of whom 56% were discussed by a dedicated heart team and 44% by a general heart team, that there was a composition that included surgeons, which we know about, interventional cardiologist, and then, of course, the imaging component. And the imaging cardiologist had to have expertise in advanced echo for mitral valve pathology. They only looked at mitral valve disease in this cohort, and had to have greater than 100 transesophageal echoes annually, as well as be certified to perform transesophageal echo. And in that study, they actually showed for the first time, again, a survival benefit to having that type of team discuss the care of your patient. And so now we have actual evidence that the heart team and the components of that heart team are essential. In addition, the EACVI, through the European Society of Cardiology, has developed a document looking at the role of the structural heart imager in the multidisciplinary heart team and the path of patient care. And in this setting, obviously, they've defined what we've done for many years, the role of the imager in patient selection, procedural planning, procedural guidance, and then in follow-up. But in fact, the new role for the imager is really in understanding the complex pathophysiology of the disease process, whatever that might be, the development of best practices within structural heart disease interventions as far as imaging, and then innovation within structural heart disease. And these are roles that are seen throughout the work in aortic, mitral, tricuspid valve disease, which I'll concentrate on today. And obviously, imagers are participating in many other procedures as well. But we'll concentrate on aortic, mitral, and tricuspid valve disease, and then go through each of these valves and each of the different steps. And hopefully you'll bear in mind these new roles in understanding pathophysiology, development of best practices, and then innovation within the field. So aortic valve patient selection first. And clearly the definitions of the different stages is something that came from imaging. Symptomatic severe high gradient is obviously concordant echocardiographic measures of aortic valve severity. And then you have the discordant measures. So you have a small valve area calculated by the continuity equation, but a mean gradient that's low. And in this setting also the LV ejection fraction is reduced. And then you have the paradoxical low flow, D3, where the ejection fraction is normal. And so these are all stages that were actually defined by echocardiography. And we know that the approach to the D2, so patients with low ejection fraction, defined currently as less than 50%, is a dobutamine stress echo to determine whether or not you have true severe aortic stenosis. And so we go down the pathway trying to increase stroke volume and determine contractile reserve, and then determine whether or not the valve area stays small, but the mean gradient goes up, which is true severe aortic stenosis, versus the mean gradient staying low, and then the valve area actually increasing into the moderate range, consistent with pseudo-severe or moderate aortic stenosis. And in the setting of an absence of contractile reserve, then at one time, we didn't know what to do with those patients. I mean, should they go to surgery? Should they not? The D3 patients were a little less easy to understand. And yet, when we look at the patients that we're treating, we can see that frequently they have severe concentric hypertrophy and diastolic dysfunction, typically restrictive disease, which would then reduce their forward stroke volume. We also know that in aortic stenosis, there's a reduction in mechanical function. There may be fibrosis within the myocardium, and therefore abnormal mechanics becomes part of why we have normal ejection fraction, but a low stroke volume. Tachycardia, frequently an accompaniment of severe aortic stenosis, again, an attempt to improve cardiac output, is also known to cause low stroke volume. This is a pacing study, where the patient is their own control, and you can see that there's a gradual reduction in stroke volume as you increase the pacing rate. And then finally, hypertension. These patients are elderly, they have stiff arterial trees, and therefore they frequently present to us with hypertension. And you can see in this patient that came to the cath lab for the PARTNER 1 trial in the setting of severe hypertension was given nipride within the cath lab, and you can see the mean gradient go up, and then this patient indeed qualified for the trial. And then finally, anything that causes reduction in forward stroke volume, tricuspid regurg, mitral stenosis, all of those will contribute to a normal looking left ventricular ejection fraction, but reduced forward stroke volume. And so how do we then know that these patients actually have aortic stenosis? And that comes from imaging. So this was a really seminal paper by Maria Nick Clavel who showed, and this is from Laval, who showed that indeed those patients with discordant grading were very heterogeneous, but that a large percent of those patients ended up having a high calcium burden. And therefore, they were able to develop cutoffs to determine severe aortic stenosis from pseudo-severe. And these are the cutoffs we use today. So in our new guidelines, it's quite clear that we need to optimize blood pressure before assessing. It's in our new guidelines. We use low-dose dobutamine, particularly in those patients with low ejection fraction. We can use it in those with normal ejection fraction, but we have to be cautious about restrictive disease. And then the aortic calcium score is extraordinarily helpful in determining which patients have true severe aortic stenosis. But when we look at this pictorial graph of a patient's progression from non-severe aortic stenosis to severe aortic stenosis, you can see that there's a really narrow green zone of optimal timing, and that frequently we're getting to the patients too late. We're waiting for them to have symptoms. We're waiting for them to have syncope, or obviously we hope not sudden death. But in any case, the optimal timing of before left ventricular decompensation is difficult to understand. And the issue that we've come to know is that it's not just aortic stenosis is not just about the valve, it's actually about the ventricle. And so the timing of valve intervention becomes crucial, and this is where imaging again comes into play. And we've looked a lot at asymptomatic disease and determined that patients who are asymptomatic with a low ejection fraction, less than 50%, can be intervened upon. And certainly those patients who are asymptomatic from their severe aortic stenosis, but who are undergoing cardiac surgery for other indications, should have aortic valve replacement. And these are all class 1 indications. And yet we've learned a lot, again, from imaging. And this is a study showing that in patients with less than 55% ejection fraction, conservative management was associated with increased mortality. Other studies have also shown that mortality is significantly worse, not only less than 50%, but less than 60%. And therefore, our new guidelines also say that there is a class 2A recommendation for a 2B, recommendation for those asymptomatic patients with an ejection fraction of less than 60%. Again, it's a ventricular disease. So we know that there is a fibrotic response to longstanding pressure stimulus, and therefore histologic changes involve both interstitial diffuse reactive fibrosis as well as focal replacement fibrosis. And so we've learned that by echocardiography, we can look at left ventricular global longitudinal strain and see that mortality actually is indeed significant, even at ejection fractions of greater than or equal to 60%. So perhaps we can actually get to these patients even earlier. And toward that end, if we used our other modalities, so this is again looking at CMR, and diffuse fibrosis, which occurs early, is potentially reversible and can be mapped again by extracellular volume mapping or native T1 mapping, and then replacement fibrosis, which is an irreversible and later phenomenon identified by late gadolinium enhancement on CMR. So then the algorithm for treatment of those patients with asymptomatic disease, which obviously is the topic for the early TAVR trial, another trial that's currently ongoing, is to look at those patients with reduced ejection fraction, but of course we now believe that the low ejection fraction for AS is less than 60%, and look at global longitudinal strain, and then evaluate by cardiac MR. And so we have an algorithm which is heavily biased toward the use of advanced imaging and multimodality imaging for disease pathophysiology. What about procedural planning? Well, this is just an example of some of the devices that had been in development or are currently still in development and under trials. And so in the TAVR world, this was one of the first TAVRs that was done. It was an antegrade approach, and you can see the result. So we had horrific paravalvular regurgitation, but we had also torn the mitral valve. And so this was the beginning of using fluoroscopic imaging, of course, where we began to learn that the best practices for TAVR could actually be within imaging. And so lots of expert consensuses were developed starting in 2011. This is just a smattering of all the documents that have been written on best practices for imaging and assuring technical and procedural success. Let's just focus a little bit on paravalvular regurgitation. Early on, we used to size the valve by just using the sagittal plane, linear dimension in a long axis view. Seems kind of silly now, but indeed that's what we did. And the 2D measurements were obviously not adequate because not only were we not measuring the right location, so we were trying to center leaflets in the middle of the aortic valve, and in truth, the biggest dimension is down in one of the commissures and hitting only one cusp. But we also failed to really realize the elliptical nature of a alveolar tract in the stenotic valve. And so it becomes more and more elliptical and as well as calcified. And it's not a circular structure, and therefore the use of area perimeter by 3D TEE or MSCT, so CT scan, may be more valid, and indeed was really proven very early on. So CT has now become really the standard of care for pre-procedural imaging prior to TAVR. And it not only determines fluoroscopic angles and vascular access, but looking at the calcium burden, the calcium location, and sizing, of course, the annulus. Procedural guidance, obviously, initially was all up to fluoroscopic guidance as well as echocardiography. So initially, TEE was mandated for the partner trials. And you can see now that this is a really mature procedure, right? So you don't really need to have transesophageal echocardiography anymore within the procedure. And so COVID actually pushed our lab forward into fewer and fewer transesophageal echoes given the aerosolization risk. And so we now do probably about 85% of our patients with monitored anesthetic care and transthoracic imaging, with fluoroscopic imaging now becoming the major imaging modality for guiding the procedure. However, just to give you a little historical background as to what we did, but also what we currently still do, is to image either by transesophageal in those 15% of cases that we still use transesophageal, or by transthoracic, to help them place the wires. And these are wires that you can see in the middle, and then the two panels on the right, where the wire is now wrapped around the mitral valve. So we need to obviously have that wire pushed out into the apex in order to prevent any mitral injury and also stabilize the wire. These are patients that had pacing wire perforations, and you don't really know that they've had the perforation until after the wires are taken out. And so we watch very, very carefully, both looking for the wire location, making sure that it looks like it's stable, and then after, in order to immediately determine whether or not there's a complication such as tamponade. We still help position, even by transthoracic. And so on transesophageal, you see the two examples where we were attempting to avoid the bulky calcification of the sinotubular junction, and we're able to successfully ask the interventionist to push the device in slightly during deployment, and therefore avoided the aortic root injury. But this is also us. You see the STJ, you see the top of the stented, crimped stented sapien 3, and we're helping position here as well. And then, of course, paravalvular regurgitation. There are instances where the patient may have renal dysfunction. You're not going to use a lot of contrast. And we're really the first assessment of paravalvular regurgitation, because I don't want to take the wire out in order to do an aortogram. And so therefore, by transthoracic or by transesophageal, we are the first to assess the severity of paravalvular regurgitation and the need for further intervention. But really what we're in there for, even for transthoracic imaging, is for hemodynamic emergencies. So I'm just going to show you a couple of those. This is you've already seen tamponade from a wire perforation, and this was tamponade right after deployment. And you can see that there's extravasation of the dye into the pericardial space, so we've perforated. And so this was a high-risk annulus, and we actually perforated the subannular space. And this is a hematoma forming just under the left main, causing left main obstruction. The patient had been converted immediately to general anesthesia and TEE, and then a second valve was placed emergently to tamponade the annular or subannular rupture. And indeed, this patient survived without going to surgery. We also early on noted that if we deformed the aortic root, that we risked perforation. This is a periaortic hematoma. And therefore now during transesophageal imaging in high-risk aortic valves and roots, we are imaging constantly in order to make sure that when we see deformation of the aortic root, that they slow the inflation in order not to perforate the aorta. They allow the tissue to expand. This is another complication we had recently, a left main obstruction secondary to a flail left coronary cusp after a basilica. You can see obviously the flail and then the severe aortic regurgitation. An urgent TAVR was then performed, and then this was the first image that we saw when we looked for the left main, and we saw turbulent flow, which, as you know, we're perpendicular, we shouldn't see anything almost, that we had occluded the left main or partially occluded. And the IVUS showed the same. There it is right there, poking into the left main. We went ahead and stented, and this patient did very, very well. And so those are the types of things that we still want to use the TEE for, the high-risk features of bulky calcification, low-lying left coronary, need for annular sizing. We frequently size on TEE without the use of CT in those patients who have renal failure or come in with a CT that's just inadequate or a non-contrast CT. And then left main risk will frequently BAV and watch for the risk as pre as well as post valve deployment. But what about after the valve goes in? So you've all seen this study. This is the study by Raj Makkar looking at thrombus within the neosinuses after TAVR. And it occurs in all valve types, including surgical. And the phenomenon is still one that we're watching. Later studies showed that in a huge percentage of patients, this resolved spontaneously. In other patients, they were treated with anticoagulation and resolved their thrombus. And we don't know what the role of thrombus might be for ongoing valve deterioration and structural valve failure. And so a number of investigators have gone ahead and defined what HALT and HAM are, and these are ongoing studies again now that we are looking at the long-term consequences of this phenomenon. Again, Philip Blanca, an imager out of Vancouver, instrumental really in looking at this phenomenon and defining those abnormalities associated with thrombosis of the neosinus. And you'll see it plays a role later on when we talk about structural valve deterioration. This is just an example where, and I'm sorry this one doesn't play, but where we saw thrombus by transesophageal echo as well. And so this is in the VARC-3 document that is really in press. It should be out any day now, where we're looking at not only non-structural deterioration or prosthesis patient mismatch, but also those stages of structural valve deterioration, all of which were defined by work that has been done in both the partner trial as well as the core valve trials, using echocardiography as your main way of determining failure of the valve. But I think the future, again, will be in the ability to predict progression of disease. And in that instance, we may be using PET scan. This is just one of the studies out of Mark Dweck's lab looking at PET and the ability to predict future stenotic calcification of both bioprosthetic as well as they've also published on native leaflets. Let's move on to mitral valve patient selection. So we start again looking at many of our new expert documents. This is the expert consensus decision pathway that was updated from 2017, again showing that imaging plays the major role. So right after the clinical cardiologist is the imaging expert. And so that imaging expert helps to define the entire path of the patient's treatment algorithm. The European Society of Cardiology has just published as well the management of secondary MR in patients with heart failure, so a position paper out of their councils. And you can see that the heart team, which is well defined in that document, also again includes the imaging specialist. So I think everyone agrees. In our own document, in our own guidelines, we clearly state that TEE, CMR, as well as transthoracic, obviously, as the first line of diagnostic testing, are very useful in class 1 indications. We know, obviously, that the first step is to define morphology. And so this is, again, all based on echocardiography, as you can see here, defining type 1, which is normal leaflets, type 2, which is excessive motion, restricted leaflet with during diastole and systole, and then restricted leaflet predominantly during systole. And this is our type 3B that we'll frequently are treating these days. And the other thing that we've been able to identify is that this leaflet override, anterior leaflet override, is not prolapse. So these leaflets, neither leaflet falls behind the annular plane, and therefore this is not prolapse. And amazingly enough, in the definition of who we should be treating is clear in our documents. It's only the high or prohibited surgical risk. But the Repair MR trial will try to answer whether or not moderate risk patients would do better with surgery versus MitraClip. And even in that trial, about, I think, 10% of patients are being sent in who don't have primary disease, but have secondary disease. So it's interesting that the education process needs to be an ongoing one. And to define whether or not you have primary or secondary disease still remains a question in many investigators' minds. And so we need to do a little bit better job on teaching. But for secondary disease, the guidelines take directly from the COEP trial. And so the considerations of transcatheter edge-to-edge repair based on favorable anatomy, LVEF, LVN systolic dimensions, and pulmonary artery systolic pressures. When we grade mitral regurgitation, obviously Bill Zogby has been instrumental, just really instrumental, and really I consider a mentor of mine, but has been instrumental in advocating for the grading of all regurgitant disease. And here you see that we've divided the categories into mild, moderate, and severe, but based on fairly strict criteria of quantitative regurgitant, orifice area, regurgitant volume, and regurgitant fraction. And the issue that became clear early on is that PISA, particularly with functional disease, was underestimating the severity of mitral regurgitation because of this elliptical orifice. And therefore, you only have a narrow orifice in one plane and then a very wide orifice in the other. And we're assuming that this is a hemisphere when it's a hemiellipse. And therefore, Bill was really instrumental in forming a consensus between the ACC-AHA guidelines and the ASC guidelines to come back to what severity definitions should be and not base them on prognosis. We all know from early solved trial days that mild mitral regurgitation has a bad prognosis in ischemic disease. And so it's not a surprise that the prognosis is worse starting at an EROA of 20 millimeters squared, but that doesn't define severe. Severe is a quantitative measure, and prognosis is something different. So, but when we use CMR imaging, is also included in our guidelines, and I think that CMR may be one of those methods that we can use to break the tie, for instance, in patients with moderate or moderate to severe disease. And the role of CMR also in extracellular volume with primary regurgitation has already been shown. You can see in this study that diffuse interstitial fibrosis, regardless of the etiology, was independently associated with symptoms related to mitral regurgitation as well as clinical events. So we may in the future again use CMR for prognosis. Procedural planning, I really probably don't don't need to go over this, but there are a lot of different devices that are out there now. Obviously, the main one is going to be transcatheter edge-to-edge repair, and our guidelines clearly state that you need to have favorable anatomy, and as we've already gone through, that you need to fulfill all these other criteria for secondary in order to intervene on secondary disease. And so morphology is our strong point. I mean, we're really good at morphology, and so looking at either a three-dimensional or this is a biplane, but two-dimensional imaging by echocardiography, particularly for pre-procedural planning, transesophageal echocardiography is one of the main things that we do. It's very clear, again, that we need to look for this anterior leaflet override, and there will be topographical maps by 3D that would become very automated and allow us to understand the differences between the primary and secondary disease, but also predict failure of the device based on anatomic criteria. And the reason we really need to know about primary and secondary are not just the guidelines, which obviously have different criteria for intervening, but also because we're going to base our clip strategy differently, whether or not it's primary MR or secondary MR. And this is just a chart from the Global Expand study looking at when to use XTR, NTR, and now obviously we've got G4, which allows for a wide clip as well as a narrow clip. And therefore, many of these charts become obsolete the minute that they're published, because we're constantly changing what we see as favorable or unfavorable based on not only the development of the new devices, but the development of new imaging capabilities. And so this is my chart of easy, challenging, and difficult. It's just about imaging. So it's good imaging, good anatomy, that's easy. Poor anatomy, but good imaging, that's harder, but we'll do it. And then the poor anatomy, poor imaging, and there's just no way to get a clip in. So to me, almost all of this is about imaging capabilities. And toward that end, I think the ultrasound companies have done a tremendous job in improving our capabilities. These are some of the examples of what would have been in the past considered to be difficult imaging, and yet all of these patients underwent TEER at our institution and had less than 1+ mitral regurgitation. In addition, we're using CMR and CT scans for other ways of looking at the disease process. And this is just D.D. Wang's paper on looking for risk of LV alveolar tract obstruction at the time of TMVR in the setting of MAC. And really, this type of work and the not only the 3D printing, but the virtual 3D capabilities have allowed us really to understand the disease process better and to advocate for our patients and do the right thing. Procedural guidance, again, ultrasound companies have been working on this and have done a tremendous job. I mean, these are obviously pretty pictures, but it's just a sampling of what the companies have attempted to do to make our lives easier, to make communication better within the procedures, and to actually make the procedures more precise. And so there is indeed enhanced visualization. Our go-to imaging tool is now live 3D multiplanar reconstruction. The newest versions of the software allow us to reorient every single plane, any plane, all four, in order to communicate better with our interventionalists. For us, we maintain the commissural view in the green plane. That means the long axis and your clip arms are going to be in the red plane. Your short axis, which allows you to align your clip arms with your red plane, are in the lower left and right hand images. And then you can go ahead and concentrate on whichever image you want. In this case, we're going to do the clipping on 3D using a larger frame for the long axis view. And then these are beautiful images, of course, but we've, perhaps for mitral clip, maybe it's just that, a beautiful image, but it does give you a very, very rapid assessment of where the regurgitant jets are and exactly how big they are relative to each other. So clearly the medial jet is a little bit, these are trivial jets, but the medial jet is slightly bigger than the lateral jet, very clearly seen on the glass view. And so these are things that allow us to work very rapidly, make rapid decisions within the procedure, and have really changed the way that we do things, not just for the mitral valve, but for all other valves. Follow-up is obviously going to be an issue for us always when a device goes in. And so once the device goes in, again, this was spearheaded by Bill and really have to thank him for doing this. But we've outlined using graphs and charts exactly the non-invasive measurements that need to be done, the parameters that need to be looked at during the procedure and after by transesophageal echo. Emphasizing not only the color Doppler, but of course, all the pulsed wave Doppler that become extraordinarily useful as well. One of the main ways that we know the patients will do well is to look at a pulmonary vein systolic reversal, since there are now 2 studies out there showing improved outcomes, and this is survival outcomes, in those patients who can either normalize their systolic flow or at least change from reversal to blunting. And so those are important measures to make. But where we may be going is use of CMR. There are obviously still pitfalls of CMR, and the utility of this needs to be determined. And obviously, Deepan Shah's leading the mitral reverse study, which is a prospective multi-center study looking at CMR in the mitral clip population, determining whether or not there is remodeling and what determines a good reduction in mitral regurgitation. So we really look forward to the outcomes of that trial. We'll move on to tricuspid valve disease. This is obviously the area where I'm doing most of my research. And we now have really begun to understand that there is both atrial functional and ventricular functional regurgitation similar to the mitral side. And so atrial functional associated with dilated annulus out of proportion to the ventricle. Atrial size, therefore, markedly dilated. These are patients that typically have atrial fibrillation. The ventricular size, this says normal or slightly increased. They typically, by the time we see them, are dilated, but the shape of the ventricle looks pretty good, very conical, versus those patients who end up having ventricular functional, where you can see again the leaflet restriction, marked increase in ventricular size with reduction in function in the setting of relatively normal or at least not as big right atrial sizes and normal function. But where we still need work is in the determination of severity of regurgitation. So far, we're relying heavily on PISA. And you can see here that in these patients, who you can actually see the orifice area of 2 centimeters squared, the regurgitant orifice area. It's really hard to categorize that as just severe. And so the patients that we end up seeing end up having much more severe disease. And PISA, we know from the work on the mitral side, underestimates severity. So does it also underestimate severity on the tricuspid side, which is even more classically has a crescent-shaped regurgitant orifice. And so we have worked heavily to define not only the methods that are advocated by the guidelines, which is PISA and 3D VCA, but also to look at volumetric methods of calculating regurgitant volume, quantifying it, and then calculating regurgitant orifice area. And in doing so, this comes from our core lab, we were able to show that the PISA EROA that would be defined by severe using a multi-parametric method was an EROA of about 34, and this is uncorrected. So it corrected, it'd probably still be 40 centimeters squared, but uncorrected of 34 millimeters squared, sorry. And then the 3D VCA that correlated with that was 60 millimeters squared, and the Doppler EROA was 65 millimeters squared. So 3D VCA and EROA by Doppler were correlating very, very closely. And then the average VC cutoff, the diameter cutoff, was greater than or equal to 9 instead of 7. Now, other investigators have looked at that. We're not the only ones, and have shown very similar findings that there indeed is this group that can be defined by higher grades of regurgitation, the massive and torrential patients who are coming to us now with signs of right heart failure wanting intervention. And so we've outlined in this review article the multi-modality assessment of TR, understanding that since then 4 manuscripts have come out, again showing that indeed there is a progressive hazard associated with increasing grades of tricuspid regurgitation by PISA. These are all EROA by PISA, such that although this was, again, showed the hazard of 1 starting a little higher, other studies have clearly shown that the hazard starts at an EROA of somewhere around 35 and then is just continuous going up. And therefore, the increasing grades are important. And I think the lessons learned from MR need to be followed also for tricuspid regurg, which is that prognosis does not equal severity, that we can continue to grade based on our usual severity scales, but understand that perhaps moderate also has a signal. The new horizon, obviously, is multi-modality imaging for TR severity quantification. And so really look forward to some of the sub-studies that are now being performed for some of the randomized controlled trials in TIR. There's a sub-study headed by Joel Cavalcante on CMR in TIR, and we look forward to that. But where tricuspid regurgitation gets super difficult is the quantification of right ventricular function. It is indeed right ventricular function that determines outcomes in both surgery, as well as we now know, as well as in the transcatheter realm, and this is all from registry data. We don't have randomized controls yet, randomized control studies, but we need to be able to quantify the right ventricle. And so this is a study that comes out using a specific program that can look at both global strain in a three-dimensional sphere, as well as longitudinal, radial, and anteroposterior strain. And we do believe that there will be differences that are seen, and perhaps we can, similar to the mitral side and the aortic side, be able to detect early those patients who may be on the road to right ventricular failure. But in addition, we would hope that we would be able to use CMR as well in order to look at not only strain, but 4D flow and RV fibrosis. It's a very complex field, and we're just beginning. So anyone that wants to pick a valve to look at, please pick tricuspid valve. I mean, it's formerly been forgotten, now is been remembered, but obviously we have such a long way to go in understanding the pathophysiology of tricuspid regurgitation and its relationship to the right ventricle and the pulmonary arterial circulation. Procedural planning, again, because tricuspid regurg came after aortic, we now know that CT is extraordinarily useful. And so we use the CT to look at the annulus, the right atrial, right ventricular dimensions, the IVC, SVC size and orientation. This is how we're getting our devices in. We understand all the adjacent anatomy as well as fluoroscopic angles from CT. This is just an example of the measurements that can be made in order to predict sizing of devices, location of anchors. It's extraordinarily useful to use CT. And we now understand that the CT measurements of the IVC to right atrial angle are also what helps determine success of the procedures on the tricuspid side. So the angulation, this is an acute angle that you see here, is going to make it much more difficult. The secondary bend on the guide is going to be extraordinary, which therefore makes it a little more difficult to get the device centered on the tricuspid valve annulus. But where we've come a long way is in understanding how to image on transesophageal echo. And so we now have added an extra level of imaging and really hope that you'll look for the new guidelines that are being developed and almost ready to submit for publication, where the deep esophageal or distal esophageal, which I called it in this paper, but we'll call it the deep esophageal, is the extra view that we know we can now image the tricuspid valve without the intervening left heart. And so developing transesophageal screening protocols, which will be in the guideline, have been key in the success of some of enrollment, but also the technical success within the procedures for some of our trials. And the procedural guidance becomes also key. We know that the transcatheter technologies are enormous and varied, aiming at the annulus or leaflets or valve replacement devices, whether heterotopic or orthotopic, and that some of these devices have gone away. They're just not going to be used, but others are now in pivotal trials. So we have both the MitraClip and Pascal, as well as the Evoque, having begun their pivotal randomized control trial, randomized against medical therapy. But in addition, really on their heels is the rapid advancement of other orthotopic valve replacement devices. So a lot going on in the transcatheter field. And because of that, we began looking more closely at leaflet morphology, which will define probably define, and we believe the initial work has shown that it does help define success of the transcatheter edge-to-edge repair devices. And so this is a paper that was just published. It's no longer in press. It's actually been published. It's open access, so please feel free to download it with the images. And we hope that we will be able to look for success rates based on the leaflet morphology. And if success rates are lower and the expectation in pre-procedural planning is that you're not going to get a good result, then those patients now may be able to go into the trials with tricuspid replacement devices. The other new advancements, I've already shown you one of them, which is the 3D MPR. I'll probably show that to you one more time, but also the ability to have a user-defined orthogonal tilt plane. So it's no longer orthogonal, no longer 90 degrees. You can rotate it in any amount of degrees that you want, and therefore align the clip arms perfectly to follow to have clip success, to grasp the leaflets. But again, this is the new imaging tool, the real-time 3D MPR, which we used to image like this, and therefore, you know, the interventionalist was turning their heads on their side, but now we can verticalize everything and align everything perfectly so that they understand where they are in the commissural line as well as at the level of the leaflets. And 3D printing may play a role in all these devices. So this is a complex compassionate use patient that ended up with one of the first ever transcatheter devices using the Intrepid. And in order to get it in, he had two pacing wires, obviously an atrial wire and a ventricular wire. We had to really understand where the wires were and where the device was going to sit. We ended up using a side snare in order to push the atrial wire out of the way. And then we ended up using 3D MPR. This is the older version, in order to really align all of our the device in the annulus. And this is a patient that had a horrifically horizontal heart. And so you can see that the primary image was almost a transgastric view. And so from the transgastric view, we were able to use 3D imaging to reorient and get the device in. And of course, the result was extraordinarily good. And so heavily involved, heavily requiring three-dimensional imaging, even when you think that there's limitations to that imaging. The three-dimensional qualities and capabilities will allow us to still get devices in. And so the future will be probably the fusion imaging. It's already been around for 6-7 years. But I think that some of the enhanced utility of the guidance tools will make this quite useful. This is one of those tools from GE that you can indicate exactly where you think the catheter should go. This is a PFO closure after doing a Watchman device, and we wanted to close the PFO because the patient was having strokes. And so we went ahead and told them exactly where the defect was, and you can see a little light red circle. We had to darken the circle in order for them to see it. So you'll end up seeing here the darker red circle, and he's gone ahead and put the catheter directly across. We're coming down with the PFO closure device, the Amplatzer, and then obviously you can see where the original PFO was in relation to the self-centering device. And so this is just a nice guidance tool, and more is coming as we begin to explore the capabilities of ultrasound. So the percutaneous assessment, the percutaneous tricuspid device assessment after these devices has also been covered by the new guidelines. And you can see here what we expect one to evaluate in order to determine whether or not you've had success. And one of the most important things that we've looked at is actually the reduction in systolic reversal of flow. And so we've seen in a number of devices now that the systolic reversal of flow changes when we have significantly affected tricuspid regurgitation. And so similar to on the mitral side, where we're looking at pulmonary venous flow, we really want you to look for hepatic venous reversal. And I'll end with the tricuspid side with just follow-up is also we heavily rely on CT. So the echocardiographic follow-up, this is a patient that was off anticoagulation, had received an evoked device, and had to be off because of a large rectus sheath bleed. And in that setting, had restricted leaflets on follow-up, and then on CT scan, I'm sorry for the quality of it, actually had developed thrombus. And so this patient was put gently back on anticoagulation and is doing well today. But CMR may again be one of those methods. I have my own opinions about its accuracy, given the fact that the RV outflow tract contributes such a significant amount to contraction, and that the contraction pattern of the RV is cannot be described by short axis views. So it's a peristaltic motion out the RV outflow tract. So I think that there are lots of pitfalls to CMR, but in this study by Philip Lurtz, the first author is Rommel, they looked at 19 patients by CMR after the transcatheter edge-to-edge repair on the tricuspid side, and found, as we have found in many of our studies, that RV stroke volumes actually go down. RV function goes down. So the RV stroke volume goes down, but the effective forward flow, so pulmonary, we look at the RV outflow tract stroke volume, goes up. And this is obviously why we've also seen in the early feasibility trials the increase in LV ejection stroke volume, and why we think that these devices are going to work. But where we're headed is going to be 3D ICE. And so this is just an animal example of 3D ICE in the tricuspid clip. And this has been bought by Biosense, and so will become commercially available. But another solution has been to, and this again is based on imaging, is to have an integrated ICE imaging system. And this is a Millipede, which will indeed, and we're already in trials with the Millipede, use integrated ICE as well as TEE to ensure the accurate placement of their devices. In addition, I think computational modeling is going to play a role, as well as holography. So this is computational modeling of the implantation of valve in MAC, and then holography, which is already commercially available as well in a patient with an ASD. And this is one of the studies that I helped Wei Sun and his group perform, looking at computational modeling of the placement of the clips. And I do think that we will be able to model some of these things in the future and have them available to us in the procedures, as well as to model the location of our probes. This is a three-mensio planning tool in order to improve our ability to image during the procedures. And where this virtual reality and simulation come in for education really can't be underemphasized, because I think that all of these tools become extraordinarily useful for communication and for more accurate understanding of the disease process, as well as implantation of the devices. And so these are just beautiful tools that I think we have been underutilized to date. But because we are, I believe, a new subspecialty with all these challenges, and I'm running out of time, so I'm going to not go through all of them, but clearly all these challenges that have been outlined in prior opinion pieces. But even in our guidelines, it's really clear that the imager plays such an integral role in the treatment of our patients that we cannot underestimate the need for us to define the field itself, the subspecialty, the training pathways, the competency that's required. This is all in the consensus paper that Steve really helped tremendously develop, and not be reliant upon random numbers that have been generated, but perhaps look at the interventional side, where they have defined the number of cases that need to be done. And this is from the CMS document decision memo: 50 greater than or equal to 50 career structural heart disease procedures, and greater than 30 structural heart transeptal procedures, with greater than 10 being the primary operator. So we need to really look at our colleagues and try to help define the qualifications, understanding that the problem is that we have a low case volume with high case complexity, and therefore those procedures need advanced understanding of valvular heart disease and expert TEE skill levels. But how do we train those people? European Society has come up with an idea of what they're going to follow, and I think that virtual reality and simulation training is going to play a major role. This is one of my simulators, and I just took a screenshot as I was doing some simulation. But these are all going to play a role so that we don't have to practice on our patients, but can actually start our trainees off with knowledge and practical skills, as well as tactile skills, that will help them during the learning process. So remember again that the new roles are understanding pathophysiology of the entire disease process, development of the best practices within the interventions, and then innovation, not only for imaging innovation, but we have been heavily involved in device iteration. And I think that that's one of the key roles for us in the future. Thanks for your attention.
Thank you, Becky. As expected, a marvelous tour de force of a very complicated area, so congratulations on that fantastic talk. I may have done you a disservice at the beginning. I think I introduced you as an echocardiographer who needs no introduction, but clearly that was a very multi-modality conversation. I just made some notes to myself. You clearly talked about echo, transthoracic, TE, DSE, strain, then CT, left-sided protocols, right-sided protocols, MRI with 4D flow, digital modeling, 3D printed physical modeling, fusion imaging, and then even holography. So it really is incredible where this is going, and you very nicely highlighted how integral all of the imaging modalities are in this field. I had a couple of questions, but for the sake of time, I'm going to go to the audience questions, and they've come in. The first I'll share with you is from Dr. Zogby. He says, thank you, Becky, for a most comprehensive update on the role of imaging in structural heart disease. Going forward, what are your 2 to 3 top priorities to address and wish to solve in this field? Easy question. Fix 2 or 3 things.
Well, I think where we're stuck right now is in getting interventional imaging to be its own subspecialty, which will then allow us to develop the training algorithm as well as a comprehensive training program, which can then be more consistent between sites. Because right now it's very site dependent. Your experience level and what you've seen and what you haven't seen. Our site does 600 TAVRs a year, and we just hit a milestone of over 300 mitral clips, and so it's very different here than it would be at a smaller site who also needs the expertise. So I think my key thing is we need to really push to define this as a subspecialty, then try to define the training involved, and then develop that training program that can give us consistency in our imagers. And then although this is down the line, it's ultra important that hospitals and administrations understand the impact of the imager. You cannot do a mitral clip without the imager, and therefore get the compensation that they deserve in these long procedures where, at one time, Steve, we were asking the anesthesiologist not to pass the TEE probe because we got $25 if we passed the TEE probe, and that was about 50% of what we were getting for an intraprocedural TEE during TAVR. So, they said, okay, you can pass the probe, but this is ridiculous, right? I mean, we're in there and guiding the procedures and determining technical and procedural success, yet we're not being reimbursed for that, and we're not being compensated for that. So I think that those are really big problems.
Yeah, great, Becky, thank you. I think I have time for one question that came in, the last one, and it really dovetails with what you just said. So, the role that you've described, a diagnostician or a proceduralist or both? And I think that's maybe some of the challenge. How do you see that?
That's a great question, because the issue with valvular heart disease and what's happened in our institution is that all complex valvular heart disease comes to my group. We're a separate group from the regular echo lab, because what we specialize in and we've practiced for the last 12 years is quantitation of valve disease. And so we know when we can and we can't quantify when we feel comfortable with our result, and when we say, listen, we're going to need a TEE. And so I think that and this is outlined also by the ACC-AHA guidelines, that when you have a level 1 comprehensive valve center, that imager is required to have certain knowledge base and abilities to deal with valvular heart disease and quantify valvular heart disease. So I think that if you identify as an interventional imager, it involves the pre-procedural, therefore diagnostic side and clinical side. So we're seeing patients also, as well as the interprocedural guidance and the follow-up.
Fantastic. Well, thank you, Becky. I think we could discuss this topic for another hour, but of course we can't do that today. So once again, on behalf of Houston Methodist, thanks for spending your time with us today and sharing your expertise. And we definitely look forward to having you down when we can. We'll see you the next time.
Thanks.
Thanks,
No,
Becky.
thank you so much.